Good evening, friends. Once again, a warm welcome. Once again, a warm welcome from Lokmanya Tilak Municipal Medical College and General Hospital for our PG training session on Thursday evenings. If you are already logged in, you can write your comments, answers, and queries on the chat box, and we shall try to see it as and when possible and try to reply together. It won't be possible to individually reply to the chats and messages, but we shall definitely take into account of your input and interaction. Thank you. I invite Dr. Devina to present today's case.
Good evening all. My name is Devina and I'll be presenting today's Thursday clinic. So my case is about an 8-year-old boy, second by birth order, born of non-consanguineous marriage, Muslim by religion, Ansari by community, resident of Kalyan, hailing from Jaunpur, Uttar Pradesh. He was brought by the history was informed by his father, who is reliable. The chief complaints were the boy was suffering from fever since the last 6 months, along with joint pain since the last 6 months. So the history of presenting illness is around 6 months ago, the child developed fever, which was insidious in onset, mild to moderate, partially relieved by medications, intermittent, initially occurring daily with 1 to 2 fever spikes and later every 3 to 4 days, not associated with chills and rigors. Along with this was joint pain and swelling, which initially involved both the knees, along with simultaneous involvement of both the elbows. Later on, this extended to ankles, wrists, and both the metacarpophalangeal joints of both the sides. The joint pain was gradual, was more in the larger joints at the knees and the elbows. It is symmetrical, it is additive, along with restriction of movements, especially of the flexion of wrists and the knees. There was increased stiffness of joints in the morning, which slightly improved during the day. There was not much improvement, but the child said there was some improvement during the day. There was no warmth or redness noticed at any point of time. Symptomatic treatment at that point of time was given, but there was no improvement to be seen. Then from 20 December to 30 December, the child had similar complaints of fever, which was insidious in onset. It was gradual. For the first 3 to 4 days, it was daily, and then after that, it came in about every 3 to 4 days. And along with that, the joint pain came up again, this time again at the knees, the elbows, the wrists, and the metacarpophalangeal joints. Again, the complaints are similar in nature as previously described. The pain was gradual, it was more in the larger joints again, and there was restriction of movements. At that point of time, he was referred to a higher center based on outside workup, which suggested low HB, that's what the father said, and he was referred to a higher center where blood transfusion was given, and there was some improvement in symptoms. Then from 17th January, the child was admitted at our hospital for the same complaints all over again. Fever since 3 to 4 days. This time it was mild to moderate. It was again insidious in onset, relieved by medications, intermittent, occurring daily and not associated with chills or rigors. There was joint swelling and pain. There was involvement of knees, ankles, elbow joints, progressing to wrists and the metacarpophalangeal joints. So basically it started at the larger joints and then progressed to the smaller ones. And this time it also involved the atlantoaxial joints. And there was restriction of movement as well. The pattern of progression was intermittent and larger joints are more affected. There was difficulty in holding objects and flexing the knees, along with side-to-side movement of the neck. Extensive workup was done and the father was told that the child has some chronic joint disease. We tried to rule out any complaints which come with fever and joint pain, along with rash. There was no complaint of rash over face, which could be suggestive of SLE. There was no malar rash or anything. We tried to rule out rheumatic fever as well, so there was no target-shaped rash specifically. Joint pain was present, but it was not migratory in nature. There was no preceding sore throat or anything that the child could remember or the father could remember. There were no complaint of rashes leaving dark residual patches, which could be suggestive of chikungunya. To rule out HSP, that is HSP, there is no abdominal pain or any complaint of purplish patches suggestive of purpura. To rule out post-viral arthralgia, there was no viral infection that the father could remember. There was no history of bleeding manifestations, no complaint of diarrhea, which could be suggestive of reactive arthritis. We also tried to rule out Cox tuberculosis, and there was basically we also tried to rule out any uveitis, red eye, or blurring of vision, which would be part of reactive arthritis. And there was no history of travel to any endemic areas. So the child actually had a very significant past history. So the age of 1.5 years, there was history given of typical, basically febrile convulsion. The child had 2 to 3 episodes of fever, which are moderate to high grade, not relieved by medication, sudden and followed by 1 episode of paroxysmal event in the form of tightening of all 4 limbs with deviation of eyes to the left side and frothing at mouth. At that point of time, CT brain was done and the father was told that it was normal. He was not started on any fever prophylaxis and he was discharged. This was when the child was in his hometown. At the age of 4 years, child started having intermittent fever spikes which were daily initially and later occurred every 3 to 5 days. This lasted for around 5 to 6 months. So basically there were bouts of fever, there was fever which occurred daily and then every 3 to 5 days. So this thing happened, continued for around 5 to 6 months. There was generalized swelling over face. It started over the face initially and then progressed to the abdomen and then progressed to all over the body. The father also noticed what he described as yellowish discoloration, and along with he said that there was paleness of skin as well. He was told that his child has some liver disease but was not evaluated further. But he remembers that one PRC transfusion was given at an HB of 4 or 5. We don't have any documentation for the same, but this is what the father said. So at the age of 5.5 to 6 years, the child again had fever once daily for 5 to 6 days, and then which continued at fever every 3 to 4 days. Localized swellings were noticed in the axilla and near the inguinal region, accompanied with tenderness. There was again yellowish discoloration of skin with paleness, which worsened over the days, along with abdominal distension. It was noticed that during the height of fever, there was a rash on the abdomen, which was described as reddish and which faded as the fever subsided. The child was then admitted and workup was done. Some procedure was done for the localized swelling and father was referred to a higher center after being told that the complaints could possibly be due to some malignancy. The child was then transferred to a higher center with PRC transfusion, blood transfusion was given in view of low HB, and the child admitted feeling better after receiving the transfusion. After that, the child then had complaints in the last 6 months. That is what we described earlier. So the ANC history is not very significant. Spontaneous conception, supplements were taken, scans were said to be normal. There was no significant maternal history and the mother did not require any blood transfusion. Birth history, institutional delivery, it was a normal vaginal delivery, cried immediately after birth, and there was no history of NICU stay. Immunization history, the child was immunized till date. Dietary history, there is deficit in calories of around 290 kcal per day, and the proteins are fine, expected. Developmental history is appropriate for age, achieved all milestones at appropriate ages, average scholastic performance, but he has not been attending school since the last 5 months due to increase in symptoms, that is increase in the joint pain. Family history, nothing significant. There is no history of any fever or joint pain or anything, or any blood transfusions or any bleeding disorder. Socioeconomic history, he belongs to lower socioeconomic class as per modified Kupuswamy classification. So the impression, initial impression, yeah.
So there are 2 ways to approach this problem. It's a long, complicated, well-presented history as far as I'm concerned. And good work, Datta, for that.
Thanks.
So one is you go for the current 6 months problem and then add on the previous problems, or you start from the first 1.5 year history and then you go on addressing each step and then you come to the current 6 months problem. So let's start the other way around. We'll start with the last 6 months and then We'll try to add on the previous information. As of now, we work without those information. Okay? So now you have a child who is, just go to the first slide, please. We have a child who has fever for 6 months and joint complaints for 6 months. So let's discuss fever. Anybody? What is your interpretation? Anyone wants to have any more information, please feel free to ask.
Fever and joint pain over 6 months suggests a very chronic history, and and since all the major joints are involved simultaneously.
Let's discuss only the fever part first, and we'll add the joint on top of that.
So
What do you feel is the fever because of?
because inflammatory cause because of the joint pain
infection.
and swelling, then it would not have been so prolonged and recurrent.
Do you think this is a single cause of fever? I mean, would you call this a continuous fever, or whether the fever was there, became all right, and then again another reason for fever?
Continuous type.
Continuous. Anybody has any other thoughts? Yeah, go ahead. What about the joints? So we are thinking of inflammatory. Are you thinking of malignancy as a possibility? Fever for 6 months? It's possible, right? It's possible. We don't know more yet, but with or without, we are not adding joint pains as of now, but if you have history of fever, few days becomes all right, and then again fever. Though 6 months is a relatively long time for malignancy, you would have shown other manifestations.
There was no warmth or redness. So I don't accept it's an inflammatory problem. Yeah, she has clearly mentioned no warmth,
Swelling
no
and
redness.
pain is there. Swelling and pain, so that is.
Swelling and pain is there, so that's why she's saying it's inflammation.
So would you say that it's a mild inflammation?
What would
So
warmth
what is the difference between a joint disease which has pain but not much swelling, on the other hand, swelling but not much pain? You get my question? Little discrepancy between pain and swelling. Let me ask you, how does a rheumatic fever with arthritis present?
If there is not much pain on the swelling or tenderness, it could be there is two concepts, arthritis and arthralgia. So if there is more pain, it could be arthralgia.
Okay. You want to add something? So sir asked what happens in rheumatic fever.
So rheumatic fever, large joints would be involved, and one joint at a time
From
is
pain
involved.
point of view, sir is asking first.
Pain would be
Mild,
severe,
moderate, severe, or extreme?
moderate to severe.
Severe to extreme.
Yeah.
Okay. And Kare sir would have been here, he would have told you, even if you move the bed sheet on the patient's legs, they would scream of pain. So though there may not be much swelling, which could be there, but at least redness may not be there, but pain will be severe. But if you have a knee joint swelling with redness and pain, then what would you be thinking? Of various
Infection.
causes. Infection, local infection, right? Septic
Yes.
arthritis is something you would want to rule out. Or sometimes even hemarthrosis can present with extreme pain
Bleeding.
and change in color with redness. So we said no warmth and redness, and so let's take one point each and see whether we can come to a diagnosis of what type of joint problem is there. So is it arthralgia or arthritis? That's the first question.
Arthritis.
Arthralgia? Why arthralgia?
Because there is no redness and increased local rising temperature. So
That goes in favor of arthralgia?
in favor of arthralgia.
So swelling redness goes in favor of arthritis, not arthralgia, correct? But still we are saying it is arthritis. So what is in favor of arthritis?
Restriction of movement. It is pain associated with swelling with restriction of
Very
movement.
good. So pain and swelling and with restriction of movement. So there is definitely a looking at arthritis. Now what would you say about the pattern of involvement? So whenever you take history of joint, which she has nicely elaborated, you take care of various features of a joint involvement. We can go in order, or I would rather go in the order that has been presented. So what do you think about the pattern of joint involvement here? Any comments? I'll give you a hint. So is it large joints, small joints?
Large joints.
Only large joints or large and small joints?
Large and small
Is
joints.
it large first and then small, or first small and then large?
Large first. And then
Large first and then small. Are they symmetrical or asymmetrical? Symmetrical. Okay. Are the joints improving? One joint improves and the next joint gets affected? What would you call if that was happening? And that would be which condition? Rheumatic fever. Okay. And here what would you call it? What one joint's involved and you have more joints involved and you get further joints involved? Polyarthritis. Okay. I was wondering whether it's called additive versus migratory. Correct? She already said it's additive. But is it improved, the previous joint over a period of time, at least it is improving, or it is remaining same? Not. Okay. Among the pattern, is there an axial joint involvement? What are the axial joints? Later on there is involvement. Somebody said that, right? So you have, she said atlantoaxial, and she also talked about the lateral neck flexion involvement. Okay.
She said there is a problem increase in the morning and gets better as the day goes. What does it mean?
I'm just suspecting it to be a morning sickness, typical case of a morning stiffness.
Morning stiffness, she's saying. So which conditions, which type of inflammatory condition give morning stiffness? Polyarthritis.
Rheumatoid.
Okay. Okay. So what we are looking for is it an inflammatory or a mechanical problem? That is what we are trying to differentiate. So suppose somebody has osteoarthritis or old hematrosis or some periarticular problem, would they have morning stiffness which improves over a period of time, or will the pain worsen as the day and activity progresses? Worsen for mechanical problem. Very good.
So now, having said that this is where we stand about the pattern of joint, what must be the possible etiology? Have you ruled out an infection totally? I mean, she said no history of chikungunya or whatever. So it means that some infections can cause polyarthritis and fever.
So let's assume what sir is asking. Let's assume when you saw the patient early on in the disease, not today at 6 months. Okay. So when we saw in the first phase of the joint involvement, would you have considered infections?
Yeah, post-viral. Any sort of post-viral arthralgia could be one of my. Like if I just seen him 3-4 days after the complaint, then I would have thought of post-viral arthralgia. If there's complaint of fever, so that could be one of my.
What is unusual about post-viral arthralgia in this patient?
Like
Anybody?
The pattern. The pattern of involved? The pattern of joints involved.
The smaller joints are also involved, MCP joint. So in reactive, basically, like usually knee joint or the larger joints are involved.
Okay, very good. Also, in post-viral arthralgia, usually you have one or two large joint involvement. You don't have multiple joint involvement. Symmetrical joint involvement is not common, and small and axial joint involvement is even rare. Okay, fine.
So then if it's unlikely to be infective, then what kind of inflammation? Two different things, malignancy one and the rheumatological disorders another. Which one would you favor looking at this story?
Malignancy or rheumatological?
Rheumatological.
Why are you so sure about that?
Because multiple joints are involved. Multiple joints can't be involved in.
In fact, rheumatological disorders mimic very closely leukemias. Very closely.
So what other history would you like to say that would favor malignancy?
History of any weight loss and.
Okay. Okay.
Well, she said that there is no bleeding, so no leukemia. But leukemia may not
Speak in the
bleed.
mic. It's on. Say
Right?
it, you're right.
History of bone pain or any weight loss.
History of bone pains or night pains and weight loss.
So what you're trying to say is that whenever there's a long story, you also want to know what is the health status like. Does he eat when he has no fever? Does he look better when the fever is little less? Or the fever is less but the disease is on, so he is still sick. So whenever there's a long story, put that in your history, whether his health is going down in terms of sickness or appetite or activity, energy, which will tell you what it is. Could it be a sickle cell? Why not? Bony
Chronic
lesions,
conditions.
multiple. Okay.
Sickle cell.
Triggered by
It
Sickle
is
is-
chronic, so
Correct. But sickle is also
less-
chronic disease, right? They'll get multiple joint involvement.
And predominantly, although in sickle, you have smaller joints which are initially involved.
So sickle cell would come in episodes, acute episodes with pain. So it's less likely to be sickle cell.
And she said smaller joints are involved more likely than the larger joints. But could it be hemophilia? He's a boy. He's always boy, but he is a boy.
In hemophilia, sir, only one joint will be affected.
Why? He gets hit on one knee, then he gets hit on the next knee. Most of the time, if you fall, you hurt both your knees. Symmetrical. No, not necessary. No, it's not necessary. Blood transfusion in hemophilia, meaning you're saying factor would have been given. That's what you're saying. But that's probably if he has been treated. He may not have been
Bruising
treated.
and other bleeding manifestation.
Correct.
Okay.
Bruising, other manifestation, and so many multiple joints over a period of time. Again, as we said, pain is going to be a significant component if it is hemarthrosis.
And there would be some sort of family history as well. Maybe not necessarily.
May or
but
may
could
not
be.
get, but yeah.
But I don't think a rheumatological disorder needs blood transfusion. One who needs blood transfusion has a hematological disorder, till proved otherwise. Would you tell us which are the non-hematological disorders where you get a blood transfusion? Not primary hematological, still you get a blood transfusion. If there are none, but there are. You get my point? No primary hematological disorder. For example, somebody has only 8 grams of hemoglobin, but he has been ordered blood transfusion, packed cell transfusion. Is there a need? In an ICU setting, when oxygenation is an issue, and at some place, say, you are giving a 60% FiO2, and nothing more is going to happen unless there is even enough hemoglobin to carry it. At which time, even when anemia is not severe, one may have to consider a blood transfusion. This is just to kind of get another way of discussion. But coming back to that, no rheumatological disorder needs a blood transfusion.
So if it is rheumatological condition, which rheumatological condition? Let's divide them into 3 areas. One is you are looking at reactive arthritis or post-inflammatory arthritis, then rheumatic arthritis, and JIA syndromes. I mean JIA and JIA subtype. So let's discuss which one this one fits into, points for and against.
In reactive arthritis, there would be some history of blurring of vision, red eye, which would suggest uveitis, or there would be difficulty in micturition, which could suggest urethritis. We could require blood transfusion in if there is anemia, which could happen in juvenile idiopathic arthritis.
Which one?
The systemic one.
The systemic
The
one.
systemic
Okay.
one.
Agreed. That too, if there is a predisposed anemia, on top of that you have an inflammatory state, you might require. But again, we are not including the previous history, but over a period of time, if you require multiple transfusions, then again I would put that as a pointer which is not fitting into my diagnosis.
I think the only point is that it's an autoimmune disorder we are discussing. And an autoimmune disorder could also be involving many other areas. Though autoimmune hemolytic anemia classically is an isolated situation and is not a part of general autoimmune phenomena. But if you look at an SLE, for example, may come only with kidney disease and nothing else. So are we looking at some common autoimmune phenomena in which there is also something happening? Of course, anemia of chronic inflammation is severe but not recurrent. Okay, deficiency anemia is common in our country. In addition to that, anemia of chronic inflammation, all put together. But it looks little funny that this child needs a blood transfusion. We'll keep that in mind, right?
The other thing is there is no history of any complication after the first blood transfusion. Because sometimes because of minor blood group incompatibility or a mismatched transfusion, one could get acquired hemolytic anemias and then subsequent blood requirement be there for some time, which is not related to this disease. But we will not add 1 plus 1. We will just right now focus on this. So the second part is rheumatic arthritis. So you already told us why you don't think of rheumatic. Now we come to GIA. So broadly we are not getting into psoriatic and all. Poly, oligo or systemic onset. 3 things we will consider. So which one does this fit into? Or which one it does not fit into? Let's start with that. Then we'll come to...
Doesn't fit into oligo.
Doesn't fit into oligo. Okay, very good. Mathematics is easy. Yeah. So does it fit into polyarticular?
Yes.
Okay.
Symmetric joint.
Symmetric, very good. What else? What else is in
6
favor of
weeks.
polyarticular? Numbers are in favor. Symmetry is in favor.
Duration.
Duration is in favor. Severity is probably in favor. Age group, borderline, plus minus. What is not in favor? Arey, first line of the presentation, no?
Fever.
Fever, very good. So speak in the mic as far as possible. You're giving nice answers. Fever is not in favor of polyarticular GIA, right? Polyarticular GIAs don't have fever. So when you have GIA situation with fever or with prolonged fever, you are
Systemic.
already narrowing it to systemic onset, if at all, or maybe some other rheumatological disorders for which we will refer to the rheumatologist subsequently. So what are the points in favor of systemic onset GIA? Fever is there, okay. Polyarticular, okay. Multiple joints involved. Additive joint. Sorry? Chronic history. How much chronicity you need to call it SOGI?
More than 6 months.
More than 2 weeks of fever and 6 weeks of arthritis. One of the two. Okay. What else? Something more interesting is there here, which I thought would pick your attention. Anemia, okay. Very good.
Lymphadenopathy.
Lymphadenopathy. You said lymphadenopathy?
I said the father described it as localized swelling.
Sorry, I didn't pick that up. Okay, very good, excellent. What is the classical thing that you look for? Yeah, so that's why I'm doing this, correct? So what rash was described here?
Transient rash.
Rash. Evanescent. What is the difference between transient and evanescent?
It appears with fever and then
Yeah,
goes.
so technically the rash is there, it increases with fever and becomes less without fever. That is your evanescent. So it's a transient rash but associated with fever, so that it's named as evanescent or temporary. So.
A lot of chats. Okay, this is Dr. Palni Raman. He writes that when you are comparing reactive with rheumatological disorders, duration is the key. Yeah, you agree to that?
Yes, it's because we included that because we are talking about the first phase of illness.
Okay. The second comment from Palni Raman again is, when we speak about malignancy, there is more of bone pains and periarthritis contributing to pain. I thought again that was absolutely right. Then Dr. Srinivasan writes that, do we have to emphasize a little bit more on sleep and appetite in such histories?
Sir did mention that personal history has to be, we appreciate that. Yeah.
That's all we have gone through.
So since Dr. Palinaman asked this question about peri-articular problems, so on history, how do you make out whether the complaint is articular or peri-articular?
When we move, when he moves actively, the pain will be there. It is periarticular. When we move, it will not be there. That will be articular.
I don't remember correctly, but I think
you're right.
Also, the pain is throughout when there is a articular problem, whereas in periarticular it's maximum around at the end of the movement or beginning of the movement. I am open to correction on this one. Yeah. So let's go ahead and add more points to what we have already discussed. I think joint part we have discussed clearly.
I think.
Okay, negative history. So this is a complicated case and I don't mind having a few more negative histories over here, but I would have probably not added post-viral arthralgia or reactive arthritis on the simple count that in your history you already said it's 6 months old and you are now at 6 months. So if you are asked, you can say that because of this reason I have not considered, I have not gone into that.
And again, TB is not necessary. JDM also, the muscle weakness is at
the main
complaint. Okay. Yeah.
Okay.
Fine, go ahead. Yeah. So,
give us 4-year-old. The first one is febrile seizure. We will leave it
at that.
What about this now?
Any thoughts on this? So let's focus on yellowish discoloration along with paleness of skin. First of all, to me, anybody who is yellow and pale is picked up by the parent is to be given full marks. It's very difficult, isn't it, sir? Now, why I'm saying is, then I will take it with a pinch of salt whether paleness is really there or not there, though I understand that PRC transfusion was given and hence it justifies the paleness. But in general, for somebody to appreciate anemia in presence of jaundice is difficult. Sir asked, no, rheumatological with blood transfusion. Now you have jaundice with anemia. What are your thoughts? You say it.
First talk about 4-year-old with jaundice. That's not very common. Okay. You get jaundice very early, at birth, infancy, metabolic disorders. Okay. Thereafter there's a bit silence and then you come viral A, etc. Okay, 4-year itself is something odd. Not that it cannot happen, but not a common age of presentation. So what's your comment on that? And then you have a swelling, abdominal swelling, etc. Put all together. Forget for a while a blood transfusion. Okay. Without blood transfusion, what would be that disease? Any thoughts? Any thoughts? First, do you think it's a liver disease or it's a hemolytic jaundice? Because we have not heard about the urine at that time, probably they would not know. So we'll leave it at that. Do you think it could be a hemolytic jaundice? Transfusion required jaundice? Yes.
Yes.
What is against hemolytic jaundice?
So swelling over the face and over the body ultimately, that's not in favor of hemat.
Also, could it be a cardiac failure and therefore swelling and also abdomen?
Remember the hemoglobin is 4 or 5.
Give a thought, doesn't matter, you are right. But I again counteracted your statement.
So then tender hepatomegaly would also have been there.
That we don't know, right? I mean, parents may not complain of tender hepatomegaly. It's a good thought, but on history, difficult to get.
So the progression of the swelling, so in case of CHF, usually it is pedal edema and thereafter, but then she has mentioned a swelling over the face initially. So less likely seems to be.
Even the liver is not necessarily over the, it's a kidney that is there, isn't it?
Yeah. And when you have failure, what is a prominent complaint?
Breathlessness.
Breathlessness, right? Breathlessness.
Therefore it is not.
Breathlessness, correct. I mean, that is going to be a predominant complaint.
So it's a liver disease. Is it a hepatocyte disease or a biliary tract disease?
Just before that, now, when you are talking about hematological versus hepatic disease, apart from urine, one more clue you can pick up is they noticed just noticed yellow discoloration with paleness. So usually liver disease would be having more jaundice and less anemia. Hematological will have more anemia with a slight jaundice. Difficult to judge by the parents, but on your history you can ask that. So I was asking about.
And no liver disease should come with severe anemia like that.
Yeah.
So possibly that could have been a hemolytic problem. Okay, congenital, acquired. What kind of hemolytic anemia?
Acquired.
Acquired. Why are you so
4
sure?
years of
It could be the first time the child presented with something that has been going on for a long time.
So other way around, which congenital hemolytic anemia will come with jaundice and anemia?
Enzyme deficiency.
Sorry?
Enzyme deficiency.
Enzyme deficiency, okay.
Spherocytosis?
Spherocytosis, correct. I mean, that's
So what's your comment on that?
Age of presentation at 4 years. The child would have presented early in case of hereditary spherocytosis, and he is 4 years, so less likely.
Spherocytosis may present right from birth to any time and may not even present at all. So, yes, what you said to some extent, but it's a wide spectrum.
Sir, in that case, there will be family history along with mass notice by the parents or the left hypochondriac region.
okay. What else? How many hereditary spherocytosis you have transfused at 4 years? Very few, right? So usually the anemia is not so severe enough to require transfusion, and jaundice is not bad enough to be noticed by the parents. It's both ways.
And again, in a long history, we said about asking the health status, also ask about the growth. A typical congenital hemolytic anemia is a short stature. Okay, so everything can add up to that. Okay, all right.
So acquired hemolytic anemia. So where are we on acquired hemolytic anemia? Sorry, acquired hemolytic cause for jaundice and anemia. Autoimmune. Very good.
Yes, most probably it may be autoimmune hemolytic anemia, warm type, IgG, and
yeah, you are right. You are right. Go ahead.
And that's it.
Okay. You want to add anything? You have a mic.
Anemia is pretty severe in this child. Okay, generally an acute autoimmune hemolytic anemia doesn't present with 4 or 5 grams because acute anemias present early, much before they become severe. Now you can always say he was always deficient, add to that something, yes, you can always argue on that. So that looks very unusual. Okay, so to that extent, it doesn't fit in either of the two.
Also, if he would have had that much of hemolysis, he would have had one more symptom which the parents would not have missed. And what is that? Suppose he was...
Lethargy and...
No. Somebody has hemolysis from hemoglobin 10 to 4.
What happens?
Yeah, very good. Use the mic.
Hemoglobinuria, red urine.
Okay. Cola colored urine or hemoglobinuria, whichever you want to put it. So where are we now on this one? We are saying it's not sickle. We are saying it's not out of acquired also. Warm AIHA, I would still keep it, but less likely. Anything else?
But then the child had anemia again later in life, and it gets improved with the transfusion. So something chronically happening in the child and then
Correct.
Getting transiently improved with transfusion.
And every time there is jaundice?
No.
Only this time there is jaundice?
This and the
2 episodes.
Which happened 1.5 years later.
Can a deficiency anemia need a transfusion and come again for a transfusion?
With jaundice? Little
With
bit
jaundice
jaundice.
is less like...
B12 can do
B12
that.
can do that, that's why.
Because people will miss what it is. Okay, severe anemia, and then you give a transfusion, but you don't give B12. Okay, and if that is so, then is there an intestinal problem also in this cell that has added to cause B12 deficiency also? So I think we are not sure what's happening on this story. Okay, and one thing, if maybe the parents won't remember all that, but how long did it take to get out of this problem? If it quickly got better, then we feel yes, it must have been an acute onset hemolysis, and transfusion was given and everything got well. So might be, but it's difficult for them to recall all that. So, but I think your history, as Tushar said, it was a very well presented. We are just trying to see what more we could have asked retrospectively. But what you did was perfectly right. Let's see what happened in the next episode.
So now we have localized swellings noticed in the axilla and near the inguinal region. So you're thinking of lymphadenopathy, right? You want to say it's significant or not significant? Any thoughts on that?
Significant because the father noticed the swelling.
Okay, so most likely significant. Very good.
With tenderness.
Okay. And would you call it localized or generalized?
Generalized.
Generalized. Okay. And we discussed about the rash. Okay, fine. So now you have an additional lymphadenopathy and one more transfusion given. What was the interval between these two transfusions?
1.5 years.
1.5 years.
And again, yellowish discoloration of skin.
This is what the father said. He said कि बच्चा थोड़ा पीला लग रहा था, but सफेद भी लग रहा था. This is exactly what he termed it
Actually,
as.
a severe pallor of 1 or 2 grams of hemoglobin looks little yellowish.
Yeah.
And I recall a child who had a very high parasitic index malaria was sent for a severe jaundice with encephalopathy for a plasma exchange transfusion. And it was severe malaria only. So I think we'll take that yellow color as severe pallor and leave it at that.
If you would have seen some ALLs coming with extreme pallor, the term used is sallow color. And that sallow color usually, sometimes parents appreciate it as yellowish discoloration.
So why are the lymph nodes coming up in this child? Malignancy.
And the joints have not started coming up till now.
Have not. The joints started coming 6 months ago.
Why lymph nodes?
SOGI also has lymph nodes, right?
So lymph node doesn't take us somewhere else straight off.
Yeah.
Okay.
Only thing is, I asked her that the lymph nodes have come first and then the joints have come. So, is it possible?
Again, malignancy also.
Yeah, malignancy, yes, of course. But remember, in SOGIA also, fever can come up first and joints will come up much later. And same way, you can have hepatosplenomegaly. And that is why in PUO situation, SOGIA remains a differential diagnosis when the joints can come up after 2 weeks or 3 weeks also. We are being wiser retrospectively. Okay, if we would have seen patient at this point in time, we would have definitely thought of malignancy first and not thought of SOGIA without any joint involvement. Go to the next one, please. Okay, done. So
what's your summary now?
So 8-year-old boy with history of fever with joint pain and restriction of movement at elbow, wrist, knee and atlantoaxial joints, and receiving PRC transfusion with history of localized swellings over axilla and inguinal region, birth and developmentally normal, immunized till date, and anthropometrically normal, could most likely be a case of systemic onset JIA or malignancy or sickle cell crisis. But that is because of the PRC transfusion and the joint.
Nobody wants to question atlantoaxial. I've been itching to ask about atlantoaxial joint. On history, when do you say it's atlantoaxial joint? You said lateral movements involved. Correct?
Lateral.
So it would have been safer to say cervical joints, okay, rather than.
Okay.
Can we go to the examination?
General examination. Child was examined on day 5 of admission. He was examined in supine position, lean built, non-sick looking, afebrile, heart rate of 110 per minute regular, respiratory rate 26 per minute regular. SpO2 was 99% on room air in all 4 limbs. Peripheral pulses were well felt. Sugar of 118, BP of 98 by 64 mmHg in right upper limb, which fell between the 50 to 90th centile. Pallor was present. There was axillary lymphadenopathy. There was no icterus, cyanosis and clubbing. I'll describe the lymphadenopathy later. Anthropometrically, his weight lay between -2 SD to -1 SD. Length was between -3 to -2. And BMI was between -1 to M. So impression is normal. Limb length between right and left limbs, there was right limb was 28 centimeter and left was 32 centimeters. Head to toe examination, head and hair normal, there was no alopecia or anything. Face, no dysmorphic faces or any Cushingoid faces. So I was trying to elicit any history of any medication, steroids taken. Eyes, pallor present, vision was normal. There was no evidence of any dry or red eyes or heliotropy rash. Cheeks, no evidence of any malar rash. Mouth, no evidence of oral ulcers. Neck, there was neck stiffness and side to side movement. There was lymphadenopathy present in the neck. There was group 2 upper jugular, 1 into 1.5 centimeters, firm, mobile, non-matted and non-tender. In the axilla, lymphadenopathy was present. Side right axilla anterior group, 1 into 1.5 centimeters and 1.5 to 1.5 centimeters. There were 2 in number, consistency, firm and consistency, non-matted, mobile. They were slightly tender, but there was no evidence or sign of any infection in the drainage side, no warmth, no redness. Nails, there was no evidence of pitting, any subungual hemorrhage. Palms, there were no evidence of any papules over Gotron's papules over knuckles or nodules over flexor tendons. So for the examination of the joints, more specifically we did the PGALs, that is the pediatric assessment of gait, arms, legs and spine. So starting with the hands, there was some inspection, there was swelling present over the metacarpophalangeal joints. The fingers were in slightly flexed position of the metacarpophalangeal joint. There was no erythema and there was no asymmetry present. Palpation, boggy swelling was present over the MCP and the PIP joints. Tenderness was present in squeezing the joints. He was unable to make a complete fist and hold objects, and he was not able to touch the thumb with the tips of the fingers and asked to do so. So this is how it was. He was slightly flexed at the metacarpophalangeal joints and the PIP joints, and it's not very visible here, but there was swelling over the said joints. The wrist inspection, swelling present over both the wrist with joints and slight ulnar deviation. inability to completely flex the wrist. So we asked him to make a reverse namaste position and a namaste position as well. So he was unable to completely extend and flex the wrist, and on palpation there was tenderness present. And each time tenderness is more early in the morning as compared to when we used to examine him in the evening. Forearm and elbow inspection, swelling of both the elbows, this was very prominent. He was able to pronate both the forearms but unable to completely extend the elbow and the wrist when asked to put arms in front. So we asked him to put it like this, which comes as a part of the assessment. He was not able to do so. It was always in a slightly flexed position like this. He was able to supinate and flex elbow but unable to form a fist. Palpation, boggy swelling present with tenderness. We have a video of the patient, but the patient actually took discharge. It was medical advice. Arms, inspection, there was no obvious swelling or deformity seen at the shoulders. He was able to raise the arms above head and look at the ceiling. So shoulder abduction was present, but is unable to put the hand behind the neck, which is what we asked him to do. This external rotation of the shoulder was affected. Contiguous joints were unaffected, that is acromioclavicular joints and all were unaffected. Palpation, no boggy swelling or tenderness present. Then to assess the temporomandibular joints, we asked him to put 3 fingers in the mouth, which he was able to do so, and there was no such complaint of swelling or tenderness present. So coming to the legs, come to the hip joint, there was no swelling present, but he was unable to flex and externally rotate the hips. Knee joint swelling was present. This is where the swelling first started and it was prominent as well. Unable to flex the knee, but extension was present. Ankles, swelling was present, inversion present, but pain on eversion. And he was, when he was asked to walk on heels and toes, there was pain and he was unable to do so. At the knee, there was boggy swelling. So the elbows and knees, we had the most swelling. On palpation, there was boggy swelling at both, and there was tenderness present as well. And especially when we come to the toes, at the middle toe and the ankle joints, he complained of pain, and there was swelling as well. So this is a picture of what it was. Coming to the spine, so cervical spine, there was limited extension present at the spine. There was limited lateral flexion. Actually, more towards the right, he could flex more towards the left, but there was limited lateral flexion more towards the right. Neck flexion was present, and coming further down, there was no swelling or obvious deformity present. So should I show the video later on?
Don't show the video. We don't have.
Okay, fine.
Video.
Systemic examination, per abdomen, inspection slightly distended, no scars, lumps, visible peristalsis or dilated veins. Umbilicus was centrally placed and inverted. Abdominothoracic breathing was present, was not much distension of the abdomen. Palpation was soft, no guarding, no rigidity. Liver palpable 5 centimeters from the right costal margin along the mid-clavicular line. It was soft, smooth in surface, regular rounded margins and non-tender. Spleen was palpable 2 centimeters below the left costal margin, firm, anterior notch palpable, non-tender. Percussion, it was resonant except over the areas of liver and spleen, and auscultation, bowel sounds were heard. The other CVS was S1, S2 present, CNS. Tone power reflexes were normal, and air entry was bilaterally equal and clear when we came to RS examination.
Just go to the first slide of examination. The first thing that comes to your mind is there is a limb length discrepancy, right? So any comments on that? Which one is longer, which one is shorter? Forgot.
The right was shorter.
Right is shorter than the left. So which is abnormal? Both can be abnormal, but at least more likely which is abnormal. The short one is abnormal, the long one is abnormal.
Both may be abnormal, but what I think in this case is left lower limb is abnormal because of obvious effusion and swelling of one joint may lead to lengthening.
Anybody wants to contest? Put your money on the other side. No?
Because of the contractures of the joint, then the right side would be shorter.
Okay, so that's a technical catch. So if there is a contracture, one is supposed to be a running length and not standing length. So that way you will negate that part. But remember, in any chronic joint inflammatory conditions, there could be an initial lengthening of the affected side. So it's usually the left side which is longer is going to be more affected than the other side, is how I will put it. Later on, if there is burnt out disease, then that limb may not grow, that epiphyseal end may not grow, and you may have it other way around. But right now we are at 6 months in active disease. One would like to say left is more affected than the right. Okay. So what else has been added onto this? I think one more point here is, do you say this is significant lymphadenopathy? Yes? So generalized or again localized or generalized? Because only the axilla seems to be the significant part, right? Neck 1.5 is not significant. So you call it generalized or localized?
This is still generalized because there are multiple nodes involved in non and contiguous areas. So generalized lymphadenopathy is always significant.
My question was, one area has significant lymphadenopathy. The other areas have not significant lymphadenopathy. Would you call it generalized or would you not call it generalized? You get my question? Technical question. So remember, any one area has significant lymphadenopathy. Any lymphadenopathy anywhere is considered significant, and you have to say it as a generalized lymphadenopathy. So you are right in what you said. Okay, so rest of the things, whatever was on history.
I think the only other thing one could talk about is the muscle wasting. So add to that. I think she has presented beautifully. I must say that. Okay. So we are trying to say where that 1% could be added, and I think why do you want to see any atrophy of the muscles around the joint? Does it signify at all? Anyway, we have a joint problem, no? Where is the problem?
Chronicity and disuse atrophy.
And therefore, earlier science, you look at a quadricep which looks a little weak, you get an idea how long this joint has not been moving, right?
Or how chronic the complaints have been.
Also, we discussed various angles of joint involvements. One more thing which we have kept it after the examination is whether this disease has been a destructive joint disease or a non-destructive joint disease. So when you discuss rheumatic joint, it is non-destructive. It does not damage the joint. Once the rheumatic fever is gone, the patient is fine. But in SOGIA or especially in polyarticular JIA, there is a destructive joint disease, and that's why you can have this particular problem. I won't get into detail and I don't know very well, but when you get these boggy swellings, you think of it as synovitis, and Sridhar can enlighten us more on that.
Absolutely.
So
synovial thickening.
Synovial thickening or synovitis, and that may put you a little bit away from SOGIA into the realms of other rheumatic conditions.
So from the chat box, this is a little bit, I'm a bit late on this. Palni Raman has been pushing right from the beginning whether this could be mass. And why is it that we are not discussing mass as a possibility? Second is whether it could be a drug related thing. Arthus reaction, whether it could be something like DRESS, a rash, liver involvement, joint involvement,
and lymph nodes.
And the other comment was on B12. So if when you have a severe B12 deficiency, Palni Raman says that just giving B12 is more than enough. Please do not transfuse. And we have wonderful preparations in the market that can be given sublingual, intranasal, with excellent bioavailability.
So,
no, what I meant about B12 is the diagnosis is missed. And somebody gives a transfusion, give iron and B12 orally, and that may not work. That's the point. Otherwise, what has been said is absolutely right. As far as the complications are concerned, like a macrophage activation syndrome, there is a sudden deterioration. This child seems to be just vexing and waning all the time. That's why possibly not. But the point is well taken that many of these disorders could have mass coming up, and then there is liver, spleen, and multiple organ involvement. That is what possibly has happened. Here, the organs are not multiply involved. They are reactive hematologically, so lymph nodes, the liver and spleen, but not the liver disease. So to that extent, the mass would have also an organ dysfunction besides suddenly deterioration.
And usually the joint complaints are preceded before mass. Once the joint complaint starts, then if there is deterioration, then you think of macrophage activation. So here all the joint complaints have been for last 6 months, and the previous blood transfusions and liver related issues were not along the joint problems. But the point is well taken. Any patient of SOGIA you are thinking, please remember to keep mass in the back of your mind. Especially a child who is not looking well shows improvement in your CBC in form of really platelets which were very high now becoming normal, or ESR which was very high becoming coming back to normal. Start thinking that you may be heading for a mass and start acting on it.
Why did he say ESR coming down and you have a complication? Funny, no?
But when you treat also, ESR should go down, so you should feel happy about it.
I would have expected ESR to climb higher.
Why does ESR go down in macrophage activation syndrome? So I was asking.
Could ESR has gone down but the CRP has gone up? Could that happen, discrepancy? And that is why many rheumatologists do both. Any comments on that?
Sir, ESR will generally help in the chronicity more than the severity rather than the CRP.
Does ESR depend on? And is there anything in a mass that is coming in the way?
Tell me one condition where ESR is 0. Congenital condition where ESR is 0.
Only hematologist.
I hope Mamta ma'am is not listening.
What are the blood picture of mass?
Sir, if there is severe anemia, then this won't be picked up because ESR depends on the
So fibrinogen, okay, and therefore the ESR has gone down, okay. But why CRP is not gone down, and in which condition the CRP might go down, but the ESR would go up?
Rheumatological condition. Low CRP, high ESR. Which rheumatological condition you're thinking of? Yeah.
SLE, we'll see this kind of picture.
Very good. Excellent.
Because antibodies to that. In SLE there are multiple antibodies, so your CRP is down, but the ESR is high, right?
Give your interpretation. I mean, your final conclusive.
8-year-old boy with fever, polyarthritis with restriction of movement, generalized lymphadenopathy, hepatosplenomegaly in a child who is birth and developmentally normal, immunized till date to rule out systemic onset juvenile idiopathic arthritis.
Any other differential diagnosis anybody wants to add? Sridhar, you want to say something on this, on your chat box? Nothing. Okay. Fair enough.
Go to investigation.
Sure.
So on investigation, there's a trend of, so when the child, we have documentation from 20th December.
So, sorry, before you go that way,
Yeah.
let's do the other way around.
Okay.
If you are thinking of SOGIA, what is the likely CBC that you will think? What do you expect? And then we'll see what is there. Anybody? What happens to hemoglobin?
Low hemoglobin.
Very good.
And
Which type of anemia? Micro, macro, normo?
Micro.
Normo.
Normocytic,
normocytic.
normochromic with normal
Okay.
iron.
WBCs?
Yeah.
Normal to high.
Normal to
Okay. And platelets?
Elevated.
Elevated. How elevated? 1.5 to 4.5. Normal range. Can be very high. Okay. Can be in 10,000s also.
Chronic inflammation, ferritin, not
No,
a
I'm
good
just
marker.
asking for
So
CBC.
ferritin is not
Yeah.
a good marker for iron deficiency, and any chronic inflammation can give rise to an iron deficiency type hypochromic microcytic anemia.
So what is the diagnostic test for SOGIA? There is no diagnostic test for SOGIA. It's a clinical diagnosis. Which is usually elevated? Which parameter is usually elevated in SOGIA?
CRP.
Okay.
RA factor is elevated.
Ferritin. Ferritin is usually elevated in SOGIA. Okay. You want to show us this? Would you do an ANA for this patient?
Yes.
Yes. What do you expect? Positive or negative?
If you are thinking of SOGI, then negative.
Negative.
But to rule out other or
Absolutely. If you get positive, what would you think of?
SLE.
SLE. Okay. Now, so what you are saying is right. So if you see an SOGIA with a positive ANA, you would doubt your diagnosis. That's how we are taught. Having said that, in the same breath, we have been taught that 20% of normal population, 10 to 20% may have positive NA. So that's the kind of difference that we're talking about.
So from on 20th December, that's when we started documenting the findings. So HB was 7.2. The readings have been fairly on the lower side, 7.2, 6.4. That's how it has been. And 23rd Jan was the last reading. That is 9. Total leukocyte counts have not been very elevated except on 20th Jan. And platelets have been around the ranges of 5,74,000 or 6 lakhs.
Okay. Bilirubin normal.
Normal.
Okay. AST, ALT are also normal.
CRP and LDH were what we were looking at here. So CRP is elevated 161, 159, 103, and LDH we had one high value which is 831.
What is your normal value here? 500? Lab normal?
5, some 6.
5, 6. Okay. ESR? I didn't see an ESR. 103.
ESR was 103.
Good.
So that's what we were ruling out, COX basically. So ESR
Don't
was
put
103.
ESR in COX workup when you have an SOJ case.
Yeah. We were trying to rule out every
No, I understand.
other
I'm just saying, because here you are not ruling out. No, ESR 103.
Yeah.
You are not ruling
Not
out
ruling out
tuberculosis.
COX.
So,
But then the other findings that we see that
okay.
for TB.
Any comments on your first paragraph?
Which one?
The direct antiglobin test and antibody test. Bone marrow is normal, right?
Yeah. So
FNSE also showing.
FNSE was, this is the report of the, so the father had given a history of some procedure being done on these swellings. So that was the history, that was a report that was given to them that was suggestive of reactive granulomatous lymphadenitis. And they were told by the doctor there that your child probably has some sort of malignancy, and he was referred to a higher center in Mumbai. Actually, we were planning to do a biopsy here, but don't have the patient. That is the.
So what are the points against SOGIA on this report now?
ANA is positive. And DCT is also positive.
I think he saw this.
It's in the previous slide. And ferritin is lower side.
Can you make out, DCT means we are talking about autoimmune hemolytic anemias, correct? Can you get any clues on CBC about AIHA apart from anemia? And then you answer, you tell me warm gives what and cold gives what. Basically, if you get MCHC, which is very high, above 36, there are very few conditions. One is spherocytosis, right? And second is AIHA, that is your warm and warm, because they have multiple small spherocytes, and that's why their MCHC is very high. It can be 45, 48, 49, that kind of thing. Sorry?
Even the rouleau formation.
Rouleau formation. So that's the next one. The rouleau formation is more common with cold AIHA, and that's where you get very high MCV. And that MCV goes really very high in 200, 250, 300, sometimes not measurable, because all the RBCs, they stick together and give you a very high MCV. Okay.
Was there any other diagnosis given in that? Granulomatous lymphadenitis, anything like Kikuchi's?
No.
Or sarcoidosis. Early onset sarcoid can also come with fever, joint pains, and granulomatous lesion. ANA can be plus minus with sarcoid. We are not looking at sarcoid here right now because there are no skin, there are no eye changes. And usually pediatric sarcoid would have one of those. What else?
And even your B12 levels are within the normal 417. So we had done a sickling test as well to rule out sickle. That was negative. These were the radiological investigations. So USG abdomen was suggestive of moderate hepatomegaly and mild splenomegaly. On doing a USG local of the joints, so left elbow had mild free fluid in joint cavity, and bilateral knee joints had mild free fluid in suprapatellar spaces extending into joint cavity. And we had done a CT scan which is suggestive of multiple lytic areas noted in right scapula, and also noted within right humeral epiphysis suggestive of erosions. So the report actually had few lytic areas, but on discussing with the radiologist, she said that she would have added one more line. There was more erosion seen over the inflammatory areas. So she was of the opinion that it could be lymphoreticular malignancy as well, or some post-inflammatory changes. So lytic areas would suggest towards any inflammatory or malignancy.
Absolutely, yeah. Any PET scan done on this patient yet? Not done. Any joint effusion have been sent for studies? Not done.
No.
Okay.
Eosinophilic granuloma versus histiocytosis versus just malignancy, some.
Correct. Because again, like slow growing malignancies, LCH would come and they would affect flat bones. So it may be worthwhile looking at the skull also. But earlier they had done a CT which was done very early at 4 years of age, which has not picked up.
The rash is never transient if it is a histiocytosis. It's a petechial type of rash. There is a significant hepatosplenomegaly.
Actually, so one of the differential diagnosis which was given was that it could be an immunodeficiency, that could be CVID. So could it be one of those as well? Because if CVID would come up with such extensive joint involvement.
I have no clue on that. I have nothing to comment on that. I would have thought clinically of this as unusual rheumatological condition, SOGIA, first diagnosis, and then to investigate and progress further. Even malignancy, I would have put it lower down on the list, but if I have a lymph node accessible and a PET scan, I would, once I get lytic lesions, I would have gone for a lymph node biopsy, and because my bone marrow is already normal. So lymph node biopsy and a PET scan if affordable and available.
I think the only issue that you may not have picked up on the history was whether this child has received steroids. And it's likely that he has had fever, lymph nodes, joints, and therefore not only NSAIDs but also steroids. So then the whole picture totally changes. Because we have some evidence that does not fit in an SOGIA, though the general story looked like one of those. Those lytic areas, etc., is making us little uncomfortable to see what else is that. And I imagine that's not unusual that steroids are often prescribed and then the whole story kind of changes. That's the only thing. And I recall on several occasions, even a diagnosis of leukemia is not easy to make out once you have given even one dose of steroids, and everything gets messed up. And then on repeated illnesses coming up, suddenly the whole story comes up. So we may have to follow this very, very closely, right?
So the granulomatous lymphadenitis, does it match with the SOGIA diagnosis?
No, it does not match. Because whatever I remember is of SOGIA, it gives you non-specific reticuloendothelial proliferation or something similar to that. I am also not sure what exact histopath is shown in SOGIA. But granulomatous word for me means either, as you say, either tuberculosis, Kikuchi or sarcoid. I would stay with these three.
Kikuchi goes on to become SLE also.
Yeah.
So when you pick up Kikuchi, you work them up for SLE.
Absolutely.
And so the other thing that was throwing us off was the fever spikes that were there. So in SOGIA, it's said that it has quotidian type of fever, only one spike a day, so which was not there in this case.
Correct. But again, just like every other disclaimer, this is the standard or the usual pattern, and there can be variation. And again, as I said, it's not classical for SOGIA also, because it's now going on for 6 months and you have such strong previous histories. But again, with this much history and this information, I would have put that as upfront as first and investigated to rule that out. And you have already done your bone marrow and lymph node aspiration, both of which have not shown me malignancy. So my other question was why an HRCT was planned.
Actually, we were planning to start the child on steroids and other this thing. So we want to rule out any other
tuberculosis or infection. Correct.
That's when this came up.
Because unless you have localized pains and other things. So as I said, I remember one case where the child was brought to me for pain in the back because the kids were playing and the elder one banged the kid onto the wall, and when I examined, there was pain, severe localized pain on the scapula, and X-ray was showing some suspicious lesion. So we said this doesn't look like a crack. So they insisted we want to go further, and then we did a CT, and that showed a lytic lesion, and it turned out to be an ALL. So this was just a coincidence which we picked up. That's why I was wondering why an HRCT was done.
And like I think steroids I mentioned, even a blood transfusion can change the whole picture of malignancy. And this child has had 2-3 transfusions. So I think we have not ruled out malignancy in this child, but on a follow-up something might come up. And I recall on a few occasions where what looked like a leukemia, even the bone marrow was normal, and then this child was not apparently given steroids, but he went into remission and then came back with vengeance, and a repeat bone marrow was studied with leukemic cells. So I think being an immunological disorder, sometimes there would be, even without treatment, some kind of a apparent improvement and then coming back with vengeance. Even in HLH, happens the same thing. The treatment is not so easy, costly. Somebody refuses a treatment, he starts getting better. And you feel that yes, it was not, but then it will come back with vengeance. So all immunological disorders, even with blood transfusion, could just go into remission and come back with an aggravation.
We must think of epidemiology, 1. 2, common things are more commonly correct than rarer things. So malignancy would be rarer. Number three, you must counsel in the patient's language. So you do that, then I want to say something. If sir allows. Would you counsel them?
Consider it as an SOG.
So, आपके बेटे को in their language, right? So, आपके बेटे को जो इतने सालों से तकलीफ़ है, जो 6 महीने से बढ़ रही है, बुखार है, दर्द है जोड़ों में, इसका कारण एक arthritis would be some हाँ, like I don't exactly the हाँ, कुछ एक जोड़ों का बीमारी हो सकता है जो बुखार के साथ आता है, आपको सूजन दिख सकती है शरीर में, और इसका इलाज है कि आप ये दवाई लो. वी वुड काउंसल देम फॉर स्टेरॉइड यूज़ एंड दैट द चाइल्ड वुड फेस सम रिस्ट्रिक्शन ऑफ मूवमेंट, लाइक उसको चलने फिरने में थोड़ी तकलीफ होगी, वो हाथ और पैर हिला नहीं पाएगा जितना उसके उम्र के दूसरे बच्चे हिलाते हैं, क्योंकि उसको दर्द हो रहा है. एंड वी वुड काउंसल हिम फॉर सम.
Fine, but you have done. Yeah. I want to tell you an idea. Practice makes you perfect. So every day, whatever patient you see, you tell your phone in maximum languages what you can tell, and you will perfect. You will not humble. If you do it first time in the exam, you are gone. See, entire medicine is communication, and we miserably fail because no sentence is in one language. Some English is always there. There is only one way. You every day you learn something, put it in a phone, tell it to your phone, make a selfie video. So, and put it in social media. In that you educate the country, but you become a better communicator in Marathi, Hindi, Gujarati, English. I got books in 12 languages. So what's wrong with you? Do it.
I think many autoimmune disorders come to you in an examination, and counseling is not very easy. How do you convince a parent that it's autoimmune? And I think we know that autoimmune is molecular mimicry. So to explain the lay person, you need to tell them that some germ comes in or an intruder, and the body decides to hit it, and therefore there is a reaction to kill that intruder. But unfortunately, one of the organs of the body itself looks like that organism, and therefore the immune system keeps on hitting that organism. Nephrotic syndrome, for example, same thing, or all these autoimmune disorders. So it is like a soldier killing his own colleague, thinking that he is an enemy. So it's a mistaken identity, and therefore we do not know why this mistake occurred, but all that we can do is just to correct it and suppress it, and that is autoimmune.
I always bring up communication because, counseling because, nobody explains it better than sir. It's always a joy to hear you, sir. Thank you.
One more point we have not been able to address in this case is the positive DCT and direct antibody. The other two tests which you have got for your weak positive autoantibody and your direct antiglobulin test. All of them point towards an autoimmune hemolytic anemia, but why it has happened, except for repeated blood transfusion or some autoimmune condition, it's very difficult to say. Now, one more thing is whether this whole episode, the previous ones were an autoimmune liver disorder, and hence you have a positive ANA with cytoplasmic granules seen on that, because they are the ones who have those SM and LA and all those things positive. But again, I think we are just deviating from the fact. We'll need histopath on these two.
So, immune aberration. So, when you have an immune aberration, you could have everything. So, you could have a different picture with almost anything. That's why I thought she was talking about CVID. So, most of these immune deficiencies come with your hepatosplenomegaly, various presentations of anemia, skin rash, and you can have different phenotypes in it. So, but what is new in rheumatological disorder today is something called as chronotherapy. So, what is chronotherapy is you link medications with the biological clock. So, the pain starts, like for example, you have a rheumatoid arthritis, it is early morning pain. So we know that in the biological clock, all the inflammatory markers are going to go up somewhere starting midnight, and then they are going to peak up. So you time your medications in such a way that you tackle that, because that is the most troublesome part. So you reduce toxicity and improve efficacy. So somewhere late evening you give your NSAIDs, and you also give a sustained release steroid. So that's something new which is coming up, chronotherapy based on the biological clock.
Very well present.
Thank you.
Very well. I think today is very good. Today Tushar is going to talk about CT and MR. Okay. So every time we will have some topic of some interest, and I think today he is going to do that. So let's see that.
Okay.
Okay. This is a long presentation, but we will stop at 8 o'clock, so don't worry. And before I start, let me acknowledge Dr. Deepak Patkar and the Radiology Department of Nanavati Max Super Speciality Hospital, from whom I have taken all the images, and he has given me free hand to use it for teaching as and when I need. So before we go ahead, I have put this horrible bookmarks or markings on it because these are not my images. If they were my images, I wouldn't have bothered to do that. Can we have these two lights off so we can see slightly better? So do you want me to show you neuroanat on this, or should I just show you some representative images of the diseases? Neuroanat. Okay. Fine, then you have to be interactive, because then there's no point of me telling you anything. So these are the one on the, do we have a pointer? Pointer milega? No? Yeah, that's what I love. It's arrow, right? How come I can't see?
Want to ask questions, please. Circulate this mic.
Okay. Can you see this? Okay. So this is your, this is the coronal cut, and this is your axial cut. Okay. So simple things first. Axial means horizontal cut, coronal means vertical cut, which as if I am facing you, and sagittal is when you divide left and the right. Okay. And I will show you the most important structures. So this is, anybody?
Caudate.
Okay, head of the caudate nucleus. Come on, you know it. Globus pallidus, thalamus, internal capsule. We are only interested in this much, to be honest. Internal capsule, you have anterior limb, you have posterior limb. Sridhar is sitting here. If I make any mistakes, he's going to kill me. But Sridhar, you are more than welcome to correct me whenever you want. He is a radiologist, actually, homegrown radiologist. So anterior limb, posterior limb, and you have genu. Okay, and you have thalamostriate branches which are at an angulation from the middle cerebral artery, and that's why they are at maximum risk of getting occluded even with an edema or embolism or pressure. And then you will have basal ganglia involvement along with internal capsule involvement or primary internal capsule involvement. Internal capsule involvement gives you what kind of deficit? Dense hemiparesis with an ipsilateral, contralateral hemiparesis with facial on the same side of the hemiparesis. Okay, next more difficult one. Start from the top here. What is this? This we have already discussed. Okay. So this we have already discussed most of it. So, yeah. Next. So, we have to remember few cuts. One is when you see on the top, okay, and I don't want any radiologist to listen to this because this is a simplified version of the MRI reading that we would do. When you take a very high up cut, you don't see any ventricles. When you go further down, you see only two lateral horns of the ventricles, and they are supposed to be at an angle like this. If you see both of them parallel and close to each other, you have to think that something which should be separating them is not present. So you think about absent corpus callosum. Okay. So you look for symmetry and look for deviation from normal. Then you come further down, you see the most important cut that I showed you earlier. When you go further down, you see this cut. Remember this image, and this is the midbrain which you can see. So in the front you see the orbit, and what you see on top of is not an optic nerve, because optic nerve connects to the apex of the orbit of the globe. This is the muscle, extraocular muscle, which is seen. So don't confuse with that. The three arrows which will show you peduncle, substantia nigra, which will be blackish in color, and there will be red nucleus. These are the three things which are important for us, because you know red nucleus affection happens in Halle-Wilden's part, it is called, right? And midbrain affection happens in which encephalitis? Eye of the tiger. Vaccine preventable disease? Japanese encephalitis. Okay. 3 clues, and not more than 3 clues are allowed. Okay, then we go further down, you will see this cut where you can see this little bit of cerebellum coming up, but predominantly you see here, this is the lower part of the midbrain. It's still not like pons. And you see further down, this is where you see the pons. Can you make out? This area. So this shape has changed now from what it was earlier. So that's where you know you are at the level of pons. Now when you come at the level of pons, remember the pons sitting in the middle of the brain. There is cerebellum which is sitting behind. And this is the only small area where the CSF is flowing from. And there is this peripontine CSF collection. But more importantly, in front of the pons is the pituitary area. When I say pituitary area, because depending on the level that the cut has been taken, it can be pituitary, it can be hypothalamus, or it could be the stalk. Okay, now this is your sagittal cut, and as you can see here, you can see this corpus callosum. Sorry, I can't move this very well, but so this is your head or rostrum. Genu means knee actually, so genu is here. Then there is body, and there is splenium. Splenium means tail. So at the end of the tail, you can see a pineal gland. So whenever there is any lesion there, one would, like a pinealoma, which could be, there are 2 common types, etc. We won't get into that. But you see a pineal gland lesion, then you have certain specific clinical scenario. In front, if you see here, you can see a pituitary gland here. You can see a hypothalamus, because you know that this is the thalamus. You know this is going to be the hypothalamus. Below the hypothalamus is your optic chiasma, and below optic chiasma is the pituitary gland, which is sitting in this C-shaped structure, sella trashica. Correct? So remember this area very well, because you have few types of SOLs which come over there. We are not expected to differentiate them, but once you see a lesion in this area and you have a clinical scenario, then you can put 1 and 1 together to give the differential diagnosis, like hypothalamic hamartoma or a pituitary adenoma or a craniopharyngioma. Depends on which part of the thing is affected. Okay. Now again here, sorry. So here if you see again in one slide, you can see the thalamus. Below that is the midbrain. Further down is pons. Now imagine this section been taken horizontally. You can see the cerebellum like an onion peel on the posterior end. So you will never miss pons where it has been taken. Coming to basics, now this is going to sound funny, but sometimes when in the exam we are given an image, we make a mistake of knowing whether it's a CT or an MRI. Okay. Not only in the heat of the exam, we want to quickly make a diagnosis. And in real life, actually, it doesn't matter because you will know whether it's a CT or an MRI. All the same, if you see the bony skull vault clearly, then think of it as a CT scan. If you see that missing, then you think of it as an MRI. And if you don't see even the surrounding skin and soft tissue, then you think of it as a, what do you do for an urgent scan? Diffusion restricted image. Okay, so when you take a diffusion restricted MRI image, you more or less only see the brain matter and nothing else. Though newer MRI machines are better and they would show some things differently. So whenever you look at any MRI, X-ray or CT scan, the most important thing is to see for symmetry. Then you look for normal anatomical layout. Okay. Once you see, so we said you have to identify ventricles, you identify the grey matter structures, look at the white matter tract. And when you are interpreting it, understand the language clearly. So what I mean by language is, when you talk about MRI, you will say hyperintense or hypointense. When you talk about echo, then you say hyperechoic, hypoechoic. Or when you say X-ray, then you say hyperlucent or hypolucent. Okay. Then next discussion comes on whether this is a T1 image, T2 image, flare, diffusion or gadolinium or stroke, what is also called as contrast image in MRI. I'll make it very simple for you because I don't know anything more than that. So think of whenever you see an image which looks like an anatomical image or which looks like a highly refined CT scan, then it's a T1 image. T1 is a simple fellow where white is seen as white and grey is seen as grey. Okay, so that's your T1. If you see it other way around, then it's obviously T2. Okay, means if you see white as grey and grey as white, then you think it as T2. If you see this, it is a T2, but your CSF is not seen, then it is a flare image because it's a fluid attenuated image. Means your fluid image has been attenuated. So you don't see the fluid in that area and ventricles look dark. Diffusion I already told you, it looks different and I'll show you the image. Gadolinium means contrast image, and contrast image means when you have a plain T1, only in T1 they give contrast. They are kind people, they don't like to confuse us more. Okay, this says basically what things are bright on T1, T2 and what is the difference between them. One simple thing is always use T1 for anatomy and T2 for pathology. This is what my radiologists have taught me. So if you see any abnormality, assume that it is going to be T2. Compare it with T1 and you will know where the anatomy is. Okay, so anything bright you see other than tuberculoma, it will be T2 and it will be not bright on T1. Okay, blood and injuries are separate, we won't talk about it. Okay, so here are two images. One on my side is what, as I said, doesn't look like an anatomical image, so it's likely to be a T2 image. On the next one, if you see, the CSF has become dark, so that's your T2 flare image, right? Why do we do this? Because there are paraventricular hyperintensities which are not easy to distinguish in your first image. But you take out that white areas, and you can see them better clearly on the T2 flare image. Okay. So let me just run through some common conditions and how they look like. And please tell me when it's 8 o'clock. Don't have the timer with me. Okay, come on, somebody fast. CT or MRI? CT. Plain or contrast? Plain or contrast? So see, we have not discussed this, but for CT, there is a clue. You can see on the lower side over here, you can see this area. So sorry, I should have brought a pointer. Okay. In this area, that is your superior sagittal sinus. If that looks bright, then it's a contrast image, except when there is thrombosis. Very good, excellent. When you have superior sagittal sinus thrombosis, that will look bright even on non-contrast. But typically they would write somewhere CE, means contrast enhanced image. So this is a contrast enhanced image, and you have to describe this. You would describe as grossly dilated ventricles with basal exudate, with, you can see those periventricular lucencies. That is important to mention, because that means this is a high pressure situation and immediate action needs to be taken. Everyone loves this. Who doesn't love starry sky? Everyone loves starry sky. This is a starry sky. It's a classical for neurocysticercosis, but you don't always see them like this. More commonly you will see them in what is shown in the next image. And if you see here, this, again if you see here, this part is bright. That means this is a T2 image. This is not a flare image. And so, because this is the abnormal part, this is the perilesional edema, this is the lesion cyst with a scolex which you can see inside. Okay. So this is your NCC. Now I told you about this one, tuberculoma versus neurocysticercosis. So almost everywhere you will see abnormality on T2 and not bright lesions on T1. But because tuberculoma contains fat, they would be bright on T1 as well. Okay. So if you see this lipid area, this is T2 and still dark. This would be white on T1. So that is the exception. So when I give you rules, remember one exception. Should I repeat? Tuberculoma on T1 is bright, rest everything is dark. T2 everything abnormal is bright except tuberculoma which is dark because it is fat. Same thing for this neurocysticercosis, T2 bright and perilesional edema along with that. What is this? This is the clinical scenario. We are talking about infection, likely to be a viral infection. Yeah, HSV, right? Very good. Why did you say HSV? Temporal lobe affection, right? So that's why you have to just take some hints about what is the distribution, what is the look, what does it look like. What about this one? We just discussed, right? Which is this area now? You have to tell me. Which is this? Midbrain, right? Correct. Midbrain encephalitis is equal to Japanese encephalitis. So now you know this, whatever that sign is called, which I cannot appreciate always, that inverted tooth or tiger's eye or whatever that is called. Okay. What about this one? This is infective or peri-infective. Now what you have here, try to look at this one and tell me. There are same patient, all three images are there. You have brightness in different areas, predominantly in white matter. Grey matter areas are not affected. They are asymmetric. So what do you think this is? White matter, myelitis, affecting the brain. So encephalomyelitis. ADEM, right? So it's acute ADEM. Okay, this is hydrocephalus with What kind of hydrocephalus this is? With ex-vacuum dilatation, right? So atrophied. So this is your intrauterine infection. Let's look at some tumors. So again, as we said, you are looking at this area. What is this area? This is pituitary and around, correct? Now radiologist will tell you whether this is craniopharyngioma or hematoma or whatever. For me, it is good enough to say there is a mass displacing this area, possibly one of the three. You give me the clinical features and I will make a diagnosis. Okay? Because there is some criteria on that machine oil look and this and that, but I don't think we need to get into that. This is a difficult one. I'm just showing you the images. I don't think we are supposed to diagnose them. So when you don't see the gyri and sulci very well, then you call it either patchy gyria or you call it agyria. Okay, means there were no gyri on the side or there was patchy gyria. Here is a classic example where you should look at symmetry. Okay, I have put arrow over here, but you see this area which is different from this area, though on first look it looks similar. So what is happening is there are many more gyri, but they are very small gyri. So what are they? Polymicrogyri. Okay. And this one? So this one, no, you see here, the grey matter is inside the white matter. So grey matter is moved. So it's not there where it's supposed to be. That's why it's heterotopia. And this is your schizencephaly. And depending upon how deep it is extended, you will have type 1, type 2, etc., which you can read up. What is this one? CT or MRI? First one? CT. What is dark on CT? What is there on the skull which makes it dark? Bright, sorry, not dark. Calcium. Calcium. What is this? I've written here something there on the top. Now always look at it. Phacomatosis. Okay, so this is like tuberous sclerosis. Okay. Some more calcifications. So if you see this one, this is along the periphery. So it's something like an AV malformation. Could be Sturge-Weber. Okay. So this is an interesting image which I like to show. So if you see peripheral lesions like this, then you think of Sturge-Weber, right? If you see periventricular, then you think of CMV. You see randomized calcification, then you think of toxoplasma, right? We don't really worry too much about AV malformations, lymphomas and PMLs. But these are the common things that we look at. And of course our favorite tuberous sclerosis with dripping candle and this and that, whatever you want to put. Leukodystrophies, the feared ones, even in the case or in otherwise. But it's very simple. Common 4 or 5 leukodystrophies I know. I don't know anything more. So we'll stick to that. Okay. This is scary slide, so we won't look at it. Affect looks like a big brain, big head, big brain, and this leukodystrophy is affecting all areas. So it's Canavan's. Okay, and I'll tell you why it is not anything else in the subsequent slide. This is affecting which part? Front area, not the back area. Alexander always marches on. So this is Alexander going forward. This is only in the posterior area. What is this? Adrenoleukodystrophy. Correct? Brilliant. So this is adrenoleukodystrophy. That was Alexander, and if it was all over, you would call it Canavan's. What is left? Metachromatic leukodystrophy. Very good. So we'll show you metachromatic leukodystrophy. Before that, this one. This is from Nelson, and that's why you can't have any excuse for not knowing in the exam if they are asked. So basically, there are different age group of infarcts. So if you have infarcts of different age groups, you think of mitochondrial disease and you think of any other thrombotic state. Okay. What about this one? Periventricular with, this is not seen very clearly, but you have white band which is running vertical. It's called a tigroid pattern. So metachromatic leukodystrophy. This is more appropriate for metachromatic leukodystrophy. Generally, just remember this kind of distribution. So we have seen Alexander, we have seen adrenoleukodystrophy, we have seen Canavan, and we have seen MLD. They all four are different. And I don't know of any other leukodystrophy that you can be asked for. Okay, we won't get into this. Okay, so generally if they show you like this and then they will show you a graph, okay, so then you can make a diagnosis if you know whether this is a lipid, a leucine peak or so whatever that I don't know. Okay, then we come to vascular insults. So again, why this is a CT? Because in stroke you don't always get the opportunity to run and do a fast sequence. So with MRI, so you can go for CT. You can see here, this is your large infarct, okay, acute infarct. You can see this area is much darker than this, right? It's not come up very well on the screen, but otherwise you can make out, okay. So and it's a dense MCA territory infarct. This is your perinatal insult. You can see the atrophied brain and dilated ventricles. What is this? What is this? Where is the problem? Which area? In the ventricles. No? So what can happen in the ventricles? IVH, intraventricular hemorrhage. Keep it simple, like Hemat sir said. Common things are commonly right. Said nice thing, I remember that. Okay, this is again thoda tricky slide, but you can read this up and you can remember it. Depending on whether it's acute, subacute or chronic hematoma, how it will look different on different images. This one, again possibly recurrent infarct or. So what you have to see here is, you can see this bottom one which does not seem to have any skin or skull around it. So it's your diffusion restricted image. Remember, if they show you diffusion restricted image, that means they want you to look at an infarct, which is an acute infarct. And you can see that white area which is infarct, and try to superimpose it on the upper ka image, and you can see that little bit of asymmetry, this versus on this side, you can see the hyperlucency, right? And when you look over here, you see only the arteries. That means you are looking at an MRA and not an MRI. And you can see a cutoff, right? You can see these vessels over here, and you can see a cutoff over here. So probably this is again an arterial thrombosis. Is that a signal to stop? You can tell me, don't throw things at me. Okay, so nobody can diagnose protein C deficiency on MRI, but just to say that this is a thrombotic event which is responsible. And if you see this multiple openings and this weird looking MRA, then you are looking at moya. It's such a favorite diagnosis, no? How many you have seen? I just love that name basically. Okay. This is like a porencephalic cyst, which is old infarct, which has now dissolved the brain and left with a cystic lesion, so encephalomalacia. This is the superior sagittal sinus thrombosis that I was talking about, which you very nicely said that even in the first image you can see it and it will look brighter on the second image. Now here you see infarct like picture, but it's not confined to any particular territory. It's more peripheral and it's vaguely divided. So you think more of venous infarcts rather than thinking of an arterial infarct. Okay. Last, trauma. Okay. So in the exam, don't just mention that. Mention the fracture which is there. Mention if there is a subacute edema. Always look for any midline shift or compression image. Suppose there is a ventricle which is looking compressed, then make sure to mention about that. Like in this case. Okay. So you can see there is a shift of midline, there is compression of the ventricle, signs of raised ICT, and then there is this subdural hematoma. This is chronic because it has become black. It was white if you saw earlier. Not the same one, but acute would be bright and chronic would be dark. This is along the circle of Willis, so more likely to be a subarachnoid hemorrhage. And some spine images. So again, when I say, oh, spine images, everybody gets very scared. Spine images, we don't know how to read. But remember, when you have spine images, what they can ask you? Only 4 or 5 things can be asked. Cox spine, meningomyelocele, trauma. Or at the most, some leukemia sitting over there, one bright vertebra will be there. Nothing more can be asked. So you have 1 in 4, 25% chance of being right, even if you just throw off dice. So this is your meningomyelocele. Congenital malformations, this is tethered diastomatomyelia, where you can see 2 cords separately. This is a tight phylum. You can see the cord which is stuck, which normally the cord not supposed to be stuck. Okay. Arnold-Chiari malformation, fine, if you get it, if you have the picture, you can see the upper portion coming right down up to the cervical, first cervical vertebra, which it's not supposed to come out of the foramen magnum. Now this is a tricky one because you may almost miss it. Is this bright vertebra, correct? So it could be osteomyelitis, which could be tuberculous, or it could be a leukemia lymphoma with met sitting over there. Okay, so this is where we are. And then further going into Cox, now you can see those 2 vertebrae which are big, and you can see some paravertebral collection also. Okay, here you can see classically one large paravertebral abscess, even here paravertebral abscess. This is collapse with spine injury. Okay, and this is your normal looking vertebra with an injury. So this is your spine injury. So questions can be asked, you will put this up, how will you manage, what is the dose of steroid, how do you move the patient suspected of spine injury, etc. Okay, thank you very much. Thank you for your patient hearing, and we stop here today. We meet again next Thursday, same time, 6 o'clock. Thank you very much.